Welcome. If you are just joining us, you are joining us for Mental Health Matters in Early Childhood with presenter Dr. Megan Lukasic. Megan, will you just advance to the next slide and we'll do a brief intro. We are welcoming today Dr. Megan Lukasic. She is the manager of Rady Children's Hospital San Diego's Developmental Evaluation Clinic. She is also a licensed psychologist. She specializes in assessment of infants and young children with developmental, behavioral, and early mental health concerns. She was, in addition to currently being the manager of the Developmental Evaluation Clinic, she is also the former clinical director of Rady Children's Hospital's Kids Start, which is a program for children ages 0 to 5 with complex needs. Megan, I'd like to turn this over to you. Welcome.
Thank you, Dana. And I promise I don't look that pixelated in person. It's very nice to meet you all virtually. I'm going to just give you a little overview about what to expect during our time together. One of the things I really like to do when I'm thinking about a presentation I want to give or when I'm attending one is I like to think about what are some tools that I can give or get in my toolbox that I can apply right away. Tomorrow when you go to work, what are some things that you'll be able to say, I can use that. So that's really that's something I kept in mind as I was creating this talk. And we'll start with talking a little bit about, the kind of so what factor. Why are we talking about mental health in little kids, birth to 5? What are some signs and symptoms of infants, toddlers, and preschool age children? And how do they compare to older children, adolescents, adults? I want to talk a little bit about the interesting history of mental health assessment and diagnosis. And then I wanted to highlight a few developmental and behavioral disorders that we see in young children. This is by no means an exhaustive list, but I picked a few that I think are particularly interesting because of how much they overlap with each other and about how surprisingly common they are. So we'll talk about PTSD, post-traumatic stress disorder in young children, attention deficit hyperactivity disorder or ADHD, autism spectrum disorders or ASD, fetal alcohol spectrum disorders or FASD. I want to talk about depression and suicidal ideation and behavior in young children. And then not to the degree that you'll see in March when that talk is presented, but I do want to talk about resiliency and protective factors to keep in mind as we're helping and working with our young families. So I'm a clinical psychologist and I work with kids birth to 5, and my husband is also a clinical psychologist and he works in the prison system. So one of the things that we talk about is how my job is really to hopefully help the young children so that they don't end up growing up and coming to see him and need him. And I think that's really important in terms of thinking about the so what. Why do we care about early childhood mental health? Well, it's not hard to think about it. And I want to highlight a person here we're going to call Jimmy, and he's here on our left side, the older person here. He's 24. And I want you to picture Jimmy in prison. He's incarcerated. It's not his first time. He has no friends and no family connections. He's severed ties with everybody. He has a history of violence, and he has a long history of drug and alcohol abuse. So working with Jimmy is certainly important, but it's tough. It's hard to change behaviors at this point in time. But we don't have to rewind too far back to realize these issues with Jimmy were evident when he was very, very young. If we look on our right side, there's Jimmy at 10 months old. At that point, he'd already been removed from his parents. He was removed and placed in another home from birth. He's now in his 3rd resource or foster home. He has there's a family history of domestic violence, and he was born prenatally exposed to drugs and alcohol. Now, if you look at these things and kind of crosswalk, to the different areas, looking at things like the home environment, social support, genetic disposition, and substance use, You can see the connection. And so we know that helping Jimmy isn't something we have to wait until his 20s to do. We can help him when he's very, very young. And that's really important. Jimmy is already telling us just by those factors that surround him that he needs our help. The National Alliance for Mental Illness gives us some numbers to talk about adolescent and adult mental health. And when we think about these numbers, they're pretty startling. And I'm sure you all have heard in the news about the growing concerns about mental health needs in our world right now. These numbers are startling, but they're actually probably an underestimate because these are just ones that are reported. But given that, we've got 1 in 5 adults in the United States who are experiencing mental illness each year. And of those, about 1 in 20 adults have a serious mental illness. 1 in 6 youth ages 6 to 18 experience a mental health disorder each year. And 50% of all lifetime mental illnesses begin by age 14, and 75% begin by age 24. We know that suicide is the second leading cause of death among people ages 10 to 34. Then when the Center for Disease Control gives us numbers and focuses on early childhood, we see some even more startling statistics. And again, keep in mind, these are reported numbers. These are people who've already been through the system and been able to have been given a diagnosis. So 9.4% of children ages 2 to 17 have received an ADHD diagnosis. 7.4% of children ages 3 to 17 have been diagnosed with some sort of a behavioral problem. 7.1% of children ages 3 to 17 have been diagnosed with anxiety. And 3.2% of children ages 3 to 17 have been diagnosed with depression. One of the things that we do in our clinic is we ask questions. We ask parents and caregivers to be the voice for their children and to report on any adverse childhood experiences. Many of you, I'm sure, have heard of the Adverse Childhood Experience, or the ACEs, which is a really important survey that is given, and it asks parents to be the voice for their child and to report on events that they've experienced, that their child has experienced some form of physical abuse, sexual abuse, or neglect. And one of the things that we know is that these adverse childhood experiences correlate highly with some of the most costly adult diseases, including cardiovascular conditions, diabetes, depression, and asthma. So because we know of the cost to our system, and not, kind of financial costs, but also the cost of what happens to young children. Think about Jimmy at 10 months old and how he grew up, and we already knew this was happening. There is no reason for us to wait to act and to help. I have a brother-in-law, and he's a super smart guy, Stanford graduate, just a really, really bright person. And when I was talking about the kind of work that I do, mental health care for children under 6, he said to me, quite honestly and truthfully, he said, well, how can you possibly, help and provide any kind of mental health care for somebody who is that young? They're not talking yet. It doesn't make any sense. And, his question was a valid one, and it's something that we hear a lot, hopefully less over time, but a question that, people just don't understand how somebody who isn't able to voice their worries or things that are going on for them, how can we tell? Well, what I told my brother-in-law and what I tell others is you can tell a lot about a young child by just paying attention to how they eat, sleep, and poop. So if we think about what a young child, a baby, is expected to do, right? They're supposed to sleep regularly, they're supposed to poop regularly, and they have an appetite and they get full. They also cry. And that's another one that I think is really important. And if any one of those things, eating, sleeping, pooping, and crying, if they're not happening the way we'd expect, we've got to pay attention to that, because those are all things that they're supposed to do. I want to shift and talk about sort of how we came into really understanding the needs of our youngest children, and how we've come to diagnose infants and toddlers. So in 1893, we had the ICD codes, and some of you have heard of those. And it's not something that we use too much in our field of mental health these days, but in the late 1800s, it's all we had, and that was our way of classifying medical diagnoses. And just as we've seen with our classification systems, there were revisions over time. By the 6th edition of the ICD classification system, they started to introduce a mental health section. And so that's where the blue are kind of significant changes over time. Then, but so they just kind of got that idea of mental health, disorders in individuals, and classifying those and targeting those for treatment. Then we had the Diagnostic and Statistical Manual, the first one in 1952. And that was really helpful in categorizing mental health needs. It wasn't until the 2nd edition, 1968, that we first started to classify behavioral disorders of childhood. We went on there for a while, but what was happening was people who were working with children, young children under the age of 6, they were looking at these diagnostic classifications and descriptions, and they were like, this isn't really capturing some of my really youngest patients. So in 1994, the first diagnostic classification system for birth to 3 came about. And this was the beginning of really trying to understand and describe disorders in our youngest children, in those infants and toddlers. It was revised in 2005. And then in 2017, it was expanded. And now we have the diagnostic classification system for birth to 5. So really, I think doing a wonderful job of helping us to talk to families about what's going on with their child, and talking to one another in a way that really is appropriate to the child's developmental level and age. So we've come a long way. And credit really goes to 0 to 3, 0to3.org. If you want a great website for looking at needs and issues with birth to 5, this is a great place to go. It has a ton of information. And one of the things that the 0 to 3 website does is it takes some of the disorders. You'll see here the different ones here: neurodevelopmental disorders, sensory processing, anxiety, mood, obsessive compulsive and related disorders, eating, sleeping, and crying disorders, trauma, stress, and deprivation disorders, and relationship disorders. It takes these different disorders and it crosswalks them so that you can find a diagnosis that fits your little 2-year-old and crosswalk it over to what would be the equivalent in the DSM-5 that we currently use for a lot of our mental health disorders, and then also to crosswalk it to the ICD-10, our current diagnostic system. And what this does is many things. Number one, it really helps us, I think, do a better job of talking about disorders in our youngest, but also, it really is helping us to inform policy and to hopefully get paid for the work that we're doing. We don't have to wait until, Jimmy is in his 20s to have to submit a bill to help him. If he's not eating, sleeping, or pooping correctly, hopefully we can start to treat those issues and also to get paid for them. So this DC classification system is really doing a lot to inform, our systems about the need to pay attention to our youngest children. And here's an example here, just one example of when you're worried about sleep. So in the DC 0 to 5, you may say sleep onset disorder. So maybe they're having trouble falling asleep or staying asleep or waking up too early. And then the DSM-5 would call that insomnia disorder. That would be the closest that it would come to that. And then for ICD-10, non-organic insomnia. So here you see a little bit more of the medical flavor, and then it gives you that code to crosswalk to. There's a lot that's really happening in terms of policy, but it's taken a long time. If we think back to when the DC first was introduced, and how long it's taken for us to be able to inform policy and hopefully, like I said, get paid for the work that we're doing appropriately so. So I want to talk now about different considerations when we're working with young children. And where I always start, and where I think an important place to start, is asking about trauma. It's one of the things that if we overlook, we may be really missing what's actually happening. So a trauma-informed approach is critical in the assessment of anybody. And certainly that is true for our youngest, who are so dependent on us to be their voice, to recognize the symptoms. You know, if they're not eating, sleeping, and pooping, we can't say, oh, well, it's okay, you know, I'm sure they'll outgrow it. Or they're not crying, well, they're such a good baby, you know, that's wonderful. No, babies are supposed to cry. That's their way of communicating to us. So we need to really make sure we're always asking questions about stress and trauma exposure, and recognizing that there are different types of trauma. So we have acute trauma, which is, you know, a one-time event, maybe one time where a child was physically abused or witnessed a traumatic event, was in a car accident. Chronic trauma, maybe living with parents who are constantly in conflict and witnessing domestic violence. Complex trauma, so that could be you know, a combination of single events and chronic events, often with somebody who is known to the child. So recognizing the different kinds of trauma, but also having an appreciation for the fact that for all of us, trauma is something that hits people in different ways, and that it's the individual's perception of the stressful event that we need to pay attention to really understand what's going on. So using a trauma-informed approach, understanding the impact of trauma and how much it can have a huge effect on behavior, development, and relationships. It's very important as when we're working with young children, to not just think about their age, but also to really think about where is their developmental level. So if I'm working with a 4-year-old, but they're significantly behind, I want to think about, well, maybe, you know, their developmental is more like a 2-year level. So what are my expectations there? Because, you know, it could be that if they're not talking, but they're 4 years old, it could be a developmental delay, maybe, as opposed to, you know, an indication of something traumatic that is happening and manifesting itself through their language. Making sure that trauma is something that if there are worries about trauma, that we're really infusing a trauma-informed approach in our treatment planning. So not just working on developmental progression and helping there, but making sure we're considering any kind of trauma that may be also coming into play. Making sure that we're thinking as providers about our role in responding to a child who's been through a traumatic event or is experiencing events. So things like, you know, being on time for a session. You know, if we're not on time, you know, what impact might this have on the child? Thinking about any kind of change. So if you have someone observing and this is new, thinking about, well, what's that like for this child who, you know, doesn't know this person? Have I done enough to, you know, make sure that they feel safe and secure with this unknown person in the room? Last week, I was evaluating a child who was brought to my outpatient clinic from a place where he's staying temporarily because he's been removed from his parents. Well, he was brought over to my clinic by a social worker who he didn't know. And he was brought to me, a person with a badge who he didn't know. And I had to really think about the fact that this little guy was having a tough time. And part of that was very likely due to the fact that the last time he had been brought over by someone with badges and seen people he didn't know, you know, in this kind of a setting, it might have been, you know, when he was removed from his parent, which was not that long ago. So really thinking about the context with which the child is presenting themselves. And then also just being really sensitive to the family. The resource parent, we're now calling them resource parents, we used to call them foster parents, the birth parent. Sometimes we're working, you know, in concert with all of the above, you know, everybody on the child's team, and really making sure that we're understanding and trying to take the perspective of each person who's involved with the child and talking to them, you know, a parent who has done things that they're not proud of, making sure that they still feel comfortable, you know, being truthful and setting the stage for honesty and not for judgment, because we know that that is the best thing that we can do for the child and for the caregiver. So early childhood trauma is different than, and kind of how it presents itself, it's different than we see in older children and adults. Traumatic events have a profound sensory impact. Their sense of safety may be shattered by frightening visual stimuli, loud noises, violent movements, and other sensations that were associated with the unpredictable, frightening event. I remember one time we had this little baby who we were working with, and there was a therapist who would come into the home and see the child. And this was a wonderful, warm, very caring and experienced therapist. But every time the baby saw this person, they had a very strong reaction and was just inconsolable and crying. Couldn't figure it out until we met the birth parent who had actually been the abuser. And their physical presentation, dark hair, kind of similar hair shape and length, that really resembled the birth parent. And so this child potentially was having that visual image kind of brought back, and they were very triggered by the therapist. And it was nothing that the therapist did or didn't do. It was just, you know, their visual presence. We know that a lot of times our youngest children, they don't have words to express that they're feeling afraid or overwhelmed or helpless. And it's our job to really step back and think, well, what could be going on here? And to really do a thorough job in our assessment of the context and the history of the child. We know that early childhood trauma has a profound effect on brain development and growth. We actually have brain scans of a child who's been neglected and a child who has not, and they're different, they look different. When we look at PET scans of activity level in the brain of a child who's been exposed to significant trauma and one who has not, it looks different. We have actual evidence of changes in brain structure and in processes. The other thing that's super important is when we're working with young children, we never work with them in isolation. It's, you know, we can't have a child come to our office and get dropped off and then picked up later by their caregiver. We have to work with the child in the context of that caregiver-child relationship. Young children are completely dependent on us for survival and protection. And that's true both physically and emotionally. And so really thinking about that parent-child, that caregiver-child relationship is super important when we're working with young children. This is a list of some symptoms and behaviors that may be an indication that a child has been exposed to trauma. So some things like returning to behaviors shown at an early age, having accidents when they were toilet trained, sucking their thumb, having fears of the dark that maybe they stopped having, or maybe they're more significant than we'd kind of expect. One that we see a lot in my work doing developmental assessments is a loss of language skills, memory problems, immature behaviors, so acting younger than their age, acting like a baby when they're now in preschool, disorganized behaviors, or what we call freezing behaviors, just kind of a startle response, changes in behavior, so acting different than they were before, significant fear of being separated from their parent or caregiver, Now, again, we have to keep in mind that, at this age, separation from one's parent or caregiver is a typically developing expectation, but kind of looking at the degree to which the child is reacting, how they respond when they're reunited with a parent or caregiver, all of these things are really important. Are they exhibiting a change in their behavior, becoming more clinging and dependent than they used to be? Are we starting to see aggressive behavior, withdrawn behavior, more crying, screaming, whimpering than was noted before? Difficulties with regulating themselves, difficulties comforting themselves, sleep problems, waking up at night, difficulty falling asleep, difficulty being able, increased difficulty being able to tolerate frustration. Effects of trauma can hit so many different areas, and it's important that we consider all of them. So the neurological effects of trauma, as we talked about, fundamental changes in structure and function of the developing brain, disruption in biological rhythms and regulatory systems, body symptoms. So, a child who suddenly has a tummy ache or is complaining of things. We were talking about the eating, the sleeping and pooping, eating, sleeping, and pooping. A child who's having a lot of diarrhea or is suddenly constipated. We've ruled out a medical reason for this. Maybe it's trauma. Problems regulating their emotions and their behavior. So, considerable difficulties with tantruming, paying attention, being highly aroused in situations, overly excited, difficulty knowing and describing their feelings in a child who does have words. So kind of what is the expectation for their developmental level and what are they able to articulate? Even if it's simple things, are they able to say, I'm scared, or to point to pictures? Attachment issues. So when we think about the child in the context of the parent or caregiver-child relationship, we expect a relationship that is built on trust and safety. If that's been challenged, it's going to affect the way a child relates to others and attaches to others. So we might see things like, poor boundaries, a child who's overly friendly. We want to really pay attention to that. That is not okay for a child to just immediately be comfortable with a stranger. We know that, that we take time to warm up to people we don't know. And somebody who immediately goes and sits in the lap of somebody they don't know, that's a concern. And something that may be indicating that they've been exposed to trauma, and we're seeing that in their relationships. We talked about the developmental impact, either a loss of previously acquired skills or a halting of their progress. So they were kind of doing pretty well with language, and all of a sudden they really showed some disruption or kind of a halting. They stopped speaking. Exacerbation of normal developmental fears. So again, fear of the dark, fear of being separated, those are expected, but is it kind of more, is it happening more significantly, more intensely than we'd expect? Social issues. So like we said, either kind of an unwillingness to engage or to engage kind of overly friendly, avoiding interaction, significant aggression between siblings, lots of behavioral issues. Behavior is a big way where kids tell us what's going on, exhibiting difficulties managing their bodies, so doing things without thinking, really impulsively, being self-destructive, hurting themselves, hurting others, being aggressive. Cognitive issues, so difficulty focusing or completing a task, knowing how to problem solve through a situation. Also, we may see some language or learning difficulties and challenges. Those are also common ways that trauma exposure can impact the growing child. I want to show this next clip, and some of you may have seen it, the still face experiment. I really enjoyed this clip because it's hard to watch, I'll tell you that if you haven't seen it, but I think it does a really good job of highlighting the impact, or well, the importance of that caregiver-child relationship and the impact on the child when it's absent. So take a look and listen here.
Babies this young are extremely responsive to the emotions and the reactivity and the social interaction that they get from the world around them. This is something that we started studying 30, 40 years ago, when people didn't think that infants could engage in social interaction. In the still face experiment, what the mother did was she sits down and she's playing with her baby, who's about a year of age.
I need my girl. Oh.
And she gives a greeting to the baby gives a greeting back to her.
Yeah.
This baby starts pointing at different places in the world, and the mother's trying to engage her and play with her. They're working to coordinate their emotions and their intentions, what they want to do in the world. And that's really what the baby is used to. And then we ask the mother to not respond to the baby. The baby very quickly picks up on this, and then she uses all of her abilities to try and get the mother back. She smiles at the mother. She points because she's used to the mother looking where she points. The baby puts both hands up in front of her and says, "What's happening here?" She makes that screechy sound at the mother, like, "Come on, why aren't we doing this?" Even in this 2 minutes, when they don't get the normal reaction, they react with negative emotions, they turn away, they feel the stress of it, they actually may lose control of their posture because of the stress that they're experiencing.
Okay. I'm here. And what are you doing? Oh, yes. Oh, what a big girl.
It's a little like the good, the bad, and the ugly. The good is that normal stuff that goes on, that we all do with our kids. The bad is when something bad happens, but the infant can overcome it. After all, when you stop the still face, the mother and the baby start to play again. The ugly is when you don't give the child any chance to get back to the good. There's no reparation, and they're stuck in that really ugly situation.
So I really like it when the mom and the baby get to go back and play together. But it is an important interaction to highlight, and you see just how social we are, even from such a young age. I mean, that baby couldn't talk, but was very communicative. Let that mom know exactly what she needed at every step, right? When the mom was being responsive, the baby was letting her know what she wanted there, pointing and vocalizing. And then when the baby wasn't getting her needs met, she also let that mom know. So I think it's just a really important thing to think about. And then thinking about prolonged exposure to that lack of interaction and what that can do to an infant, and then as they continue to grow. I'm going to segue now, but before I do, I see 2 questions. And Dana, I don't know if they're relevant, but it's a good place to stop if they are.
Sure. So we have 2 questions. The first one is about referrals for older children. So we may want to hold this one to the end, or do you want to address it now?
Yeah, we can hold that one. I think that sounds good.
Okay, and the other one, I think, talks about hospitalization of preemies. And what the person says is it can be difficult to tease out what caused what, especially when their little bodies are trying to just grow. Are there studies on trauma from hospitalization in preemies? Several parents have asked about their child remembering all the medical interventions.
That's a great question. So you're talking about something that absolutely we see medical trauma. I think it's important to, I don't know specific kind of early mental health. That's a really interesting topic to explore in infants who maybe have had prolonged stays in the NICU, but certainly we can think about, you know, that that parent-child bond and the disruption that has happened for a child who is in, you know, in a NICU, maybe who couldn't be touched. I think it's certainly something that we have to consider in a child that we have concerns about. The other thing that I think is important is to think not just about the impact of the on the child, but remember what I said about the parent-child relationship, and how when we're working with a young child, it's always in the context of that parent-child relationship. So, you know, I think about when we see a lot of children who were born premature, and parents are bringing their now 2- and 3-year-olds to our outpatient office, and they're coming to Rady Children's Hospital where maybe they had a NICU stay. And that has got to be particularly, you know, triggering for a lot of our parents. And I think that's important for us to appreciate. You know, maybe the last time they came here, you know, they're remembering back to how scared they were because they didn't know, you know, how their baby was going to do. And now they're coming to us to find out, well, how are they doing? You know, I think all of that is something that we really need to have an appreciation for and to stop and pause and think about. So, you know, I think, yes, medical trauma is definitely something to be really aware of. And I think our NICUs do a wonderful job, the medical staff there and all to support, you know, as much as we can of that attachment and connection. But, you know, it's different. And so I think that is something for us to be thinking about. So I'm going to shift now to kind of the next focus, which is on I want to highlight a few developmental and behavioral disorders, and I'm going to talk about autism spectrum disorders.
Babies.
Here we go. The reason I went from that last video to autism spectrum disorders is I think that, you know, the transition there is a good way to think about just the overlap between some of these different disorders. The importance of when we're thinking about autism spectrum disorder, which is kind of inherently at its core a disorder of social and behavioral difficulty. And when you think about that baby and how that baby was not making eye contact, had kind of a flatter affect, some of those things are things we think about in autism spectrum disorder. And so if we, you know, have a worry about autism, but we haven't asked those difficult questions about, has there been any stress or trauma exposure in a young child, we may be really missing, you know, what's going on. And I think that's super important. And also, I think, you know, thinking about some of these disorders and how challenging some of the behaviors can be, we also need to think about the fact that these children are at higher risk for increased stress and trauma. They're at higher risk for being abused because the relationship can be so challenging. And so we just see a higher rate of abuse in children with developmental and behavioral disorders, particularly when they're not understood. But autism is, you know, a diagnosis that, you know, now we're talking about affecting 1 in 44 children. You know, the rates, they keep changing, and we are, I think, doing a better job of capturing what we're calling a continuum of varying degrees of need in the areas of social development, social skills, communication. So talking about both verbal communication, you know, using your language, your words, but also nonverbal communication, and repetitive and restricted behaviors. So different mannerisms, different ways of playing. Those are all things that we are looking at when we're talking about autism spectrum disorder. You know, we talked a few slides back about some of the changes in our diagnostic classification system, and certainly we've done a lot in terms of our way of looking at and thinking about autism spectrum disorders. As of 2013, we no longer use the term autistic disorder or Asperger's syndrome. There was also another term called pervasive developmental disorder, which basically said that the individual had some symptoms of autism, but didn't meet the full criteria. We've replaced all of those terms by the single term autism spectrum disorder, with the hope that we are doing a better job of classifying a broader range of children and giving them the support that they need. One of the things with the kind of latest classification system that has been added is a 3-level system that is used to define how much support does this individual need in terms of their social communication, how much support do they need in terms of restricted and repetitive behaviors. So that's a change. Another thing to note about autism is that it is different from cognitive delay. Depending on what studies you read, about almost half of individuals with autism have significant delay, but many don't. Many have average or well above average IQ scores. Another really interesting thing that we're talking more and more about, and there's more and more literature about, is an understanding of girls with autism spectrum disorders. So we're really starting to kind of assess, take a step back and look at how have we been diagnosing. We know that more boys, 4 times as many boys are diagnosed with autism compared to girls. We also can see that more girls, when they are diagnosed, it tends to be somewhat later. So what's the reason for this? Are we doing enough to really understand when a girl has social difficulties? And are they manifested differently? There's a lot of support to suggest that they are manifested differently. Some examples there are things like girls have less repetitive motor mannerisms. Some of their socially, like their interests that are kind of classified as restrictive and limiting, they're more socially accepted. So a girl may have an interest in animals or princesses, but it's so intense that it's really disruptive to their functioning. Girls tend to have improved social communication behaviors compared to male counterparts. So they may have improved eye contact, they may use gestures more, their conversation skills may be somewhat better. So these are some differences. Another thing that we're seeing in the ASD community is more individuals with ASD identify as gender nonconforming, fluid, or trans. And so that's another thing that I think is important for us to be paying attention to and to be talking about in terms of identity. Another important kind of topic that is really interesting to me is the neurodiversity movement. Thinking about, what is our internal sense of self? I used to have, when I did talks on autism spectrum disorders, I would use the, I don't know if you've seen the ribbon with the puzzle in it. Well, a lot of, or many people in the autism community really object to that, that image. They really are wanting to encourage more education and celebration of autism as a positive identity, not something that needs to be fixed, but really needs to be accepted and potentially some accommodations made for. So I think that, really thinking about human neurological diversity as a value is something that we're seeing both and hearing a lot about, both from individuals with autism as well as family members of individuals with autism. So those are some really interesting and important topics that we're seeing more and more of in the autism spectrum literature and in just discussions. Another thing that we've seen is just changes in kind of how the media portrays autism. So those of you who are older like me may remember Rain Man, where Dustin Hoffman, really presented with some very very impressive skills, but also some clear social difficulties. And his brother, Tom Cruise, was kind of struggling to know how to interact with him. We see Greta Thunberg, the climate activist, is somebody known to have autism. Kayla Cromer is an actress who's quite open in talking about her own struggles with autism. She was diagnosed in her early teens, I believe. Susan Boyle, a singer. Many of you know The Big Bang Theory. So we have Sheldon Cooper, and now we've got young Sheldon. So that's kind of an interesting thing from a developmental continuum and appreciation for, you know, what was he like as a young child. Certainly Sheldon is somebody that those of you who are Big Bang Theory fans, you know, we see him over time really, you know, kind of both struggling with some of his social difficulties, but also, you know, he's somebody who has, and we'll talk more about this, some really nice protective factors. He has a really great group of friends, and that has really helped him in many ways, and we see his changes over time. Julia, the autistic puppet on Sesame Street, a girl with autism, and Sesame Street doing a nice job there of really educating, you know, parents and families watching Sesame Street as well as young children. Then we have Atypical, which is a Netflix series, and The Good Doctor, and these are just some. I think Parenthood is another show I really liked watching. I thought they did a nice job of depicting a high-functioning, a person who was very bright, but who struggled. At that time, they were calling him Asperger's, which, you know, again, we no longer use that term, but I thought that that show did a nice job of just really capturing the way that the family tried to understand, but also struggled at times, but continued to try to understand and support the son in that family. So I'm going to shift now and talk about another disorder that I'm sure we've all heard about, attention deficit hyperactivity disorder, or ADHD. This is a behavioral disorder where you see a persistent pattern of inattention and or hyperactivity and impulsivity that interferes with functioning or development. So this is a term that has had lots of different kind of, it's been called different things over time. At one point it was called minimal brain dysfunction, which is, I'm really glad we've moved way away from that one. Some people still like to call ADD, but we actually don't have attention deficit anymore. We have ADHD with inattentive type. But basically, this is a disorder that where we see symptoms before age 12. And very important, we see symptoms present in more than, in at least 2 settings. So typically in a child, this is home or school. And another important thing is that these are behavioral symptoms that interfere with life and are not explained by something else. So, you know, a different disorder or an event, you know, thinking about that overlap between trauma and ADHD. As you recall, some of the behavioral manifestations of trauma, you know, difficulties with attention, poor frustration tolerance, impulsivity, difficulty regulating. Those are all things that we see in ADHD, but also we see in trauma. So very important that we recognize and ask the questions about trauma when we're considering attention deficit hyperactivity disorder. ADHD also is something that is seen to have different levels, mild, moderate, or more severe. There are a lot of myths about ADHD. Some people say that it isn't a real diagnosis. And if we think about young children in particular, you know, a lot of young children, they're curious about their world, they're active, they're exploring, they're into everything. But, you know, ADHD can be real, and we can see, we don't really diagnose ADHD much before age 4 typically, but you can see if everything else has been ruled out, a very young 2-year-old who is more active, more impulsive, has more difficulties with some of those symptoms that we talked about than we'd expect for a 2-year-old. That is one to watch, and one that we want to start helping right now, because the hope is that over time, that will be less, those issues will be less challenging for them, but quite possibly they could persist. And so we know now is the time to act. The brain is really receptive to intervention at a young age, and if the child is struggling, there's no reason to wait. All individuals with ADHD are hyperactive. That is not true. We know that there is ADHD inattentive type, and those are children who often, are kind of your child at the back of the classroom who's looking out the window and not paying attention. But they're not super active the way that others may be. Another thing that is a myth is that individuals with ADHD can't pay attention. So sometimes I'll have a parent come into my office and say, my child can play video games for a really long time, so I don't think they have ADHD. And what I explain is what we're looking at is not so much how does the individual do under highly motivating situations, but how do they do under other conditions where they have to sustain mental effort, listening to, to a teacher in a classroom, especially if it's not super interesting, but we know I have to listen because I need this information to do well in the class. So that's really important. Nobody has ADHD all the time. Individuals with ADHD are not smart. That is definitely a myth. There are a lot of individuals with ADHD who are very intelligent. Another myth is that medication is the only treatment for ADHD. In young children, my emphasis is always on, let's start with behavioral intervention. If that's enough to help, then that's all we need to do. For some children, that combination, and individuals, that combination of medication and behavioral intervention, really helping to understand and manipulate the environment to get control over a situation so that a child can be successful, is going to be really, really important. But medication alone is almost never enough, but it can make a big difference. Some people that we know to have ADHD, or at least these are the rumors, Michael Phelps, and this, as the story goes, Michael Phelps his sister was in swimming lessons, and he was, the younger brother, kind of running around the pool, and the coach, I guess, and if this is not a true story, it's certainly a good one, encouraged him to get in the pool, and here we have now, a gold medalist here who's become very, very successful. Adam Levine, a rock star married to a supermodel. These are examples of individuals with ADHD who have really, found their way. They've found the path that where they can be successful, where they can take some of their symptoms of ADHD and use them in ways that are positive for them and help them thrive as individuals. And so that's what we all hope for any of us, right? Is to be able to take the things that we're challenged by and understand them, but also recognize sort of, where we can be our best selves. I'm going to shift now to another, I think, important diagnosis that I want to highlight, and that's fetal alcohol spectrum disorders. This is another really important one, especially I think when we're talking about birth to 5. Well, in general, I think as providers, it's really important for us to create an environment of safety and security where we can ask about not just drug use during pregnancy, but alcohol use. Of all the substances people abuse, including cocaine, heroin, marijuana, we know that alcohol produces the most serious neurobehavioral effects in the growing fetus. We also know that it doesn't matter how much you use, or we don't know, a specific amount that is okay, or a specific time period during the pregnancy where it's safe to use alcohol. So what we say is, don't do it. If you know you're pregnant or going to be pregnant, don't use any amount of alcohol. When we think about fetal alcohol spectrum disorders, and I won't go into the different types of diagnoses that we use for fetal alcohol exposure, but somebody with fetal alcohol syndrome has known growth defects. There's very specific facial abnormalities that can be detected upon physical exam. It also affects the central nervous system, both structurally, neurologically, and functionally. So, I'm just going to show you here a little baby who has some facial characteristics. fetal alcohol syndrome is something. Alcohol is known to affect the midline of the face here. And so we see, you know, a smooth philtrum right between the nose and the mouth, a thinner upper lip, small opening of the eyes. And as we go on and talk about, well, I'll get there in a minute, but behavioral kind of manifestations, we see a lot of problems with frontal lobe functioning. And so that's another important important consideration for fetal alcohol syndrome. Some contributing factors to fetal alcohol spectrum disorders is that 45% of pregnancies are unplanned, and that most people aren't aware of their pregnancy. Pregnancy discovery often happens at 8 weeks or later. There has been a lot of kind of misinformation about alcohol use when pregnant. I know my own mom was told to have a beer to relax when she was pregnant with my brother, and there were some worries about him. Another thing is, I think, you know, when we do ask questions about alcohol use, we tend to focus on hard alcohol, or maybe people, when they're answering that question, they're thinking about that. Well, no, I don't use vodka or tequila. Well, what about beer or wine? Making sure we're asking that as well. Also, you know, just really thinking about kind of where people are in terms of their own acceptance of their use. And that mixed message about, you know, it's okay to drink, it's not okay. Throughout time, we've really been pretty inconsistent about that. But at this point in time, really it is, if you're thinking about being pregnant, becoming pregnant, you know, don't use alcohol. So some behaviors that we see in individuals exposed to alcohol in utero. In babies, they're often irritable. They may appear nervous, may be sensitive to sound or light. They're often fussy and crying often. Or that opposite that we talked about earlier, where they're very quiet, that baby who's too good or not responsive. In children, we see aggression or defiant behaviors. We see depression, sometimes psychosis, anger problems, poor impulse control, attention problems, difficulties with problem solving, difficulties with social skills, difficulties processing information through their senses. So overly sensitive to touch or to sound, or maybe seeking out, you know, additional kind of deep pressure and things like that. So those are just some examples of some of the things that we might see. And you can think here, as we start to, you know, really kind of go through the different disorders, how much overlap there is. Childhood depression. So this is a real thing. Babies can be depressed. And some questions that are important to ask is, you know, things like, does the baby appear withdrawn? Do you see them staring into space? Have we ruled out anything maybe neurological, like any kind of seizure activity? And if so, you know, why are they doing that? It's not usual. You saw that baby in the still face experiment, how we're social beings. You know, we are kind of hardwired to want to lock into another human face. But if we're staring off into nothing, what's going on there? You know, is the baby not smiling? You know, babies, again, social beings, we respond socially at a very young age, and we use our mouths to do that. Do they express a range of different kinds of emotions? How easy is it for you to engage your baby? How quiet and subdued are they? Are they interested in toy play, you know, that you'd expect for their age? And most importantly, you know, how does how they're presenting compare to what you're used to, their usual presentation, their usual temperament? I want to tell a quick story about Daniel. This is a little guy who somebody in our clinic saw many years ago, and I think it really highlights the importance of paying attention to not just the child in front of you, but to really, you know, kind of thinking about the context of the parent-child relationship, and just, you know, what might be going on for the baby, and kind of really slowing down sometimes and asking more questions if you know you're wondering something doesn't seem right. This clinician was working with a little baby, and he came in with his prospective adoptive mother. They were about to adopt this little baby, and the baby was doing just one of the things that we said here, was not holding onto the toys. Would kind of like just, you know, you put the rattle in the hand and it would just fall out. They didn't have a range of facial expressions, was really hard to engage with this very engaging clinician. And, you know, the clinician thought enough to say, gosh, you know, is this how Daniel usually is? And the prospective adoptive mother, you know, just kind of really became upset and said, you know, this is how he's been since he's been with us. And, you know, then she proceeded to talk about a photo album that the former resource parent had passed on. And those pictures had Daniel, you know, presenting very differently. Vibrant smile, engaging in play, just a very different presentation. So a real shift. And the prospective adoptive parent said, you know, we just don't know what to do. He doesn't seem happy. We don't feel connected, but we've already sent out the adoption announcements. You know, it's kind of too late. And this clinician, you know, again, I don't know that this is something that many of us could or would do. I'd like to think I would do it. But this clinician really, you know, listened in that moment to that caregiver and kind of fast forward, really helped that family recognize that this was not a good fit and worked with the family, with the social worker, and eventually Daniel went back to his original resource parent. And the clinician was able to see Daniel many years later and reassess him, and he was a completely different child. His cognitive scores were above average, he was a happy child, and he was in a good place. And as tough as that situation was, it was really the right thing for everybody involved. And it really wasn't too late. And the time to act was in that moment. And that's exactly what that clinician did. And Daniel was certainly the better for it. I want to talk just briefly about risk for suicide and self-injury. Because, you know, I was looking at this list of kind of risk signs for suicide. And this is for children, teens, and young adults. But as I went through the list and I took my highlighter, you know, and thought about, you know, what are some things that could be impacting a very young child, even before age 6? All the yellow are things that we want to think about. And I certainly in my work have had to assess for, you know, thoughts of hurting oneself or others in a child as young as 4 and 5. And so, you know, it's not too early to start talking about safety concerns, to be talking about, you know, safety planning with caregivers. You know, do you have sharps? You know, do they have access to sharps? You know, what's the supervision like? Do you have guns in the home? Are they, you know, are they locked? Where are they? Really, again, you know, not dismissing the possibility of safety concerns just because somebody is young. So that is, you know, just a few. Those are a few of the childhood disorders that we think about. And it's by no means an exhaustive list. The DSM and even the DC 0 to 5, you know, those are pretty big books. There's a lot of different things for us to consider. And I think it's very important that we always begin with asking about trauma and stress, not only because it helps us do a better job of accurately diagnosing, but it also really then helps us move into an appropriate course of treatment for the whole family. So I highlighted trauma, PTSD, autism, ADHD, fetal alcohol syndrome, and depression. But these all overlap with other common disorders in children: oppositional defiant disorder, anxiety, auditory processing disorder. It's not a standalone diagnosis, but it's definitely one that we see and we hear a lot about. Families coming in talking about auditory processing and sensory processing concerns. I'm sorry, both auditory and sensory processing challenges. Obsessive compulsive disorder. Gifted children. I think that's an important distinction too. You know, is the child, are they really displaying problems with attention, or maybe they, you know, aren't challenged enough? Thinking about motor coordination disorder too. Clumsiness. Is this true? Are there muscle weakness concerns? Or could this be an indication of trauma? We see a lot of coordination issues in individuals with trauma. So developing an appreciation for the considerable overlap and an important emphasis on careful assessment and making sure that we're not kind of just sticking to the lens that maybe we're trained in. So I'm trained in development and behavior, but I think now, my lens has been broadened and I do a much better job of considering things like trauma and early mental health when I'm looking at a question of a developmental concern. So I want to quickly tell a story about Nathan because I think his story, it's one of my favorites. He's a little guy that I started seeing when he was 2, and I got to see him 3 different times until he was 5. And I think what's great about this particular story is, with young children, we never know where things are going to go. But I think we know enough to act as early as we can and to do everything we can to work collaboratively with as many people as possible. And Nathan is a success story. He's one of those that we really get to say, wow, this turned out cool. And so I just want to share a little bit about him with you. When I first saw him, he was at Polinsky Children's Center, which is a detention facility, and he'd just been removed from his parent. And he was just very active, very dysregulated, just really, really busy. Fortunately, when I was there to do the assessment, his mom was also there. And so I was able to get some important kind of baseline information about his functioning. And I was also able to get some family history. Now, Nathan had been removed because of mom's substance use, but she shared with me things like, she had some college and that she had been diagnosed with ADHD as an adult. So that was important information. And it was also important because I got to engage with her and to hopefully help her understand her child. And I hope she also got to see how much I really liked her child and how much I really was there, not to judge kind of her history and her story, but to help her child. And over time, this little guy was involved in a lot of services. He had many different interventions. And what was interesting about him was the kind of diagnostic impressions really varied. And different people at different points in time kind of suggested different things. And that changed over time too. I'm just going to go through some things here. But when I saw him, and I'm just sharing his IQ scores. I did a test at 2 that was a different measure, so it's not as directly comparable. But I saw him at 3 and then again at 5. At 5, he was in a prospective adoptive home. There was still communication with his birth mother, but she really was not, unfortunately, able to care for him full time. But we see a big shift in his verbal skills, and that's not uncommon in children who have been through a lot of stress for one of the areas to be impacted, that language development. And so by age 5, his verbal skills were above average. They were good at 3. They were not as good at 2. His nonverbal skills also went up some from average to above average. And his spatial skills, his ability to manipulate his eyes and his hands to do things, also increased. So here's a little guy who overall went from an average IQ to a high score in his cognitive abilities. Quite a shift. Other differences here, we do lots of different kinds of evaluation. We use different tools. One is a semi-structured play-based assessment that is designed to look at autism. And at one point for Nathan, that had been a question. The school had questioned autism, so we were looking at that. When he was 2, he did just meet classification for autism. So you could see where that was kind of why that came up. By 3, he did meet classification for autism, but by 5, he did not. And our diagnostic impressions really changed over time too, from adjustment disorder to, could this be signs of autism, what we called PDD-NOS at the time, or early signs of ADHD? Again, remembering that at 2, he was very, very busy, but we couldn't give that diagnosis because of his young age and also because he'd been through so much, and how much was it really just his way of telling us, hey guys, I'm stressed. At 3, kind of more considerations for autism, but by 5, this little guy, no diagnosis. He didn't meet criteria for any diagnosis. He'd also qualified for an individualized education program, a special education services at age 3. He no longer needed those by the time he went to kindergarten, and he was in a regular kindergarten class. So a really wonderful story about, the fact that change is possible. I think something to highlight here, though, is that, he was a lucky guy because, by the time he was 5, he was in a very stable environment. But that doesn't necessarily mean that he's guaranteed to not have a diagnosis and to have that boost in scores. That doesn't always happen. What it does mean, though, is that we did everything we could to, help him be his best self. And it just so happened that he really had some really wonderful kind of, some skills and some abilities that were just there. If we think about Mom with that college history, she was also probably very, very bright. But, I think the drugs got in the way, and the hope here is that that will be different for Nathan. Which brings to the last part here, which is protective factors and thinking about resiliency. The child, Harvard, if you look at the Center for the Development of the Child at Harvard, they do some nice work on protective factors. And I know there's going to be some trainings in March, so I won't go too much into that. But, we have some known protective factors that we can put in place for a child like Jimmy, remember the little guy we saw at the beginning of the slides, or Nathan, that can really help us to shore up the child. We can't take away when they've experienced an adverse childhood experience, but we can do a lot to mitigate those issues. And some of those things, again, thinking about Jimmy, that guy that was incarcerated who didn't have any friends, he didn't have any social support. They say, it's important to have, at least some people that you can, identify as your person, your friend, your family member who's going to be there for you. So that's an important protective factor. And it's important for us to be asking, our families, who are your go-to people? Do you have any? And if they don't, that's an important place for us to look at. Concrete supports, do they have transportation? Do they have housing? Does the caregiver understand their child's development? Sort of what's their competency about development? Do they have a good sense about what's typical in a young child? Because if they don't, that could impact the way that they parent or perceive their child. Parental resilience, what does the parent bring to, or the caregiver bring to that relationship? And we talk about ghosts in the nursery, things that, kind of came before the person became a parent, that they're bringing to their relationship with their child, and how that impacts how they are raising that child. The social and emotional competence of children, do they have an understanding of how to express themselves? What's modeled in the home in terms of, managing someone's, emotions and behaviors? In our work at my clinic, we are always asking about adverse childhood experiences. And what I love that we also do is we're then pairing it with mentioning some protective factors that the individual child has. And I think that's super important. We don't want to just focus on, the problem areas and the challenges, but also like, what are we already seeing as strengths for this child and family? So that's just a cute picture there. And one of the things that I wanted to highlight is that I think we're doing a lot of good work. I know there are a number of you here that are working with very young children, providing mental health services. We're seeing more and more of that, thank goodness, because we know it's needed. We see children before a year in mental health therapy with their caregiver, with their parent, but that's important. Our systems, though, are also doing a much better job at integrating care. So Healthy Steps is a program, I think, that is really providing some nice protection for our children and our families. This is a program that is team-based, and what they do is they go into the well child visits where children are with their pediatrician from birth to age 5, and they do mental health and developmental screenings. They offer care coordination and recommendations. They identify when there are behavior or developmental concerns, and they also ask the parents questions, and they say, you know, how are you doing and what do you need? I mean, this is super important. Just a quick story on this. In our own offices here, we have this program, and one of the screeners was in a well child check with a mom who had, I think it was 5 children, and she'd been asked questions about depression in the past, but hadn't really said anything, and for whatever reason, expressed some suicidal ideation this time. And that specialist thought enough to make sure she got some support, had one of our psychologists on our team come down and interview the mom, and just really took the time to ask the mom about safety. And this mom was super grateful, and was able to, they were able to come up with a plan of support for the mom, able to bring the dad into what was going on with the mom so that he could support her. And it was just a really great example of listening and acting in the moment. This mom, had she not had this experience, may have stayed home with her, 5 children in a very depressed state. And that would not have been good for her or for her family. Through this program, we've learned that there's a huge need for this intersection of medical and mental health needs and development. So, we've seen that about 31% of children screened on the Ages and Stages questionnaire have developmental concerns. 13% through the checklist for autism in toddlers have concerns that have been identified this way. When asking parents about their own depression, we've got 12% of parents endorsing concerns, and 4% showing social and emotional concerns in their children and worries there. And when we think about, the parent-child relationship, and then think about the impact of parental depression on the social and emotional concern of the child, we can see that these are higher. That's an even higher rate of concern for social and emotional well-being of children if they're living with a parent who's got depression. So that's really, I think, a wonderful example of some things we're doing in our community in terms of protecting and supporting and strengthening families. In the home, and this is a really cute video that maybe you guys have seen. I watched it many times, and it's just something that makes me happy. But there's this concept about serve and return. If you think about serve and return like a tennis match, this is really thinking about the caregiver-child or parent-child relationship and being responsive to our children. And this little cute video is a dad and his son, and they're doing just that. They are doing serve and return. And what he's doing is he's giving time. And this is by without question, a wonderful example of a protective factor for this family, because no matter what, this dad is present and responsive to his child. And that's just a beautiful thing. So I'm gonna let you watch this, and I'm sure I'm gonna give you a smile.
Invisible eyelid lift strips are revolutionizing the market in the US. Do you have the same problem? Then this easy...
Here we go.
Okay. They need to work on that, right? Yes, okay. Did you understand it though? No. Okay. All right. Huh? Oh, no, not this one. This is the grand finale of this one. Yeah, that's the last one. That's what I was wondering. I don't know what they're gonna do next season because they did some stuff this time. Exactly what I was thinking. Oh yeah. Right, don't bring that again. You know what I'm saying? Don't do the same stuff. You know what I'm saying? Yeah, I was thinking that, yeah. Yeah. Like go somewhere else with that, but don't bring it here. You know what I'm saying? Yeah. That's what I said. Then he was like, you know what I'm saying? And I was like, what in the world? But don't do that here. You know what I'm saying? Yeah. Yeah. Really? I thought the same thing. We think a lot alike, huh? Oh,
I know we're short on time, so I'm going to stop there. But I hope you enjoyed that. I know I particularly, I love that one. And in the few minutes left, do we have any questions? Looks like just a few maybe.
We have a pretty good number of questions. If we run over a few minutes, Megan, are you able to stay?
I am, yeah, and I'm sorry about that, guys. There's
No,
so much
no.
to talk about with this topic.
We've got some great questions here, so I know it's likely we're going to run over a few more minutes. So if you're able to stay, that's fantastic, everyone. If you can't, we will be dropping the survey link in just a minute, but I am going to go ahead and tee up a couple of questions for Megan now. So the first couple of questions are about ADHD, and they're about medication. The first is, how early is it acceptable to medicate kids for ADHD? And as a follow-up, what happens when a child has been diagnosed and prescribed medication for ADHD by a psychiatrist, but the parents decide to no longer administer the medication, but then have difficulty with the child's behavior at school?
Those are really great questions. And I will start by saying I'm a psychologist, not a medical doctor. But my answer to that is, I think, the same that the many psychiatrists and developmental and behavioral pediatricians that I've worked with would answer. And that is, we can give medication, in younger children, sometimes 4 and 5, but it's almost never, or it should not be the starting point. For most children, we recommend behavioral intervention as a starting point. And then, if that's they're still struggling, then we might move on to medication. I think, in a young child, there's different, in terms of regulations, when you can give certain medications. I think to the developmental and behavioral pediatricians and psychiatrists that I work with, would want to consider, have they had behavioral intervention? And then also just sort of like, what are the behavioral concerns? I think safety concerns are a big one. If there are safety concerns that aren't being helped with environmental controls and behavioral intervention, that's when we might move into things. But again, making sure we've ruled out other things, looking at sleep. If that's, if we haven't kind of worked on sleep, that could be a reason for behavioral issues. So we want to be not be quick to medicate a young child. In parents who, let me make sure I understand this one, Dana. Parents who that have stopped the medication, but the psychiatrist was recommending it. Is that right? Did I lose you there, Dana?
So the medication has been prescribed. Parents have chosen not to administer it, but now parents in school are seeing behavioral difficulties. So how to navigate sort of that communication issue, essentially.
Okay. Well, I think it is important to recognize, where the parents are and to take the time to understand what their concerns are. I think, again, I've been fortunate to work with some really wonderful physicians out there who take the time to understand and to listen to parents about what their concerns are, to explain things like side effects, and to think about other things. People who prescribe aren't wanting to do this quickly, and they are very thoughtful in that. So I think it's really about seeing what else can be done, but also, understanding what the worries are for the parent, as a way of understanding why not. And then also providing education, about things. So like talking about, self-medicating, children who, parents may be afraid to prescribe medication, and then children going on to, use substances as a way of medicating themselves when they get older. And so that, I think can be sometimes an effective talking point, but it really is about meeting the parent where they are, and thinking about what else can be done before going to medication.
Thank you. The next question is about depression. I'm sorry, we have one about FASD first. So is it possible to diagnose FASD after infancy?
Yes, it is. So there, just really quickly, and that's a whole presentation in and of itself. There are people who do physical exams, and they're literally doing measurements of different physical parts of the body to determine concerns in different areas, like we talked about with that baby in the face. But there's also kind of neurodevelopmental profiles of children with fetal alcohol exposure. And so, I think the most important thing in diagnosing fetal alcohol spectrum disorders is hopefully having an honest history of exposure. So talking with parents about the importance of really being truthful, because your child needs you to be truthful, and not anything that's a judgment, but really a way of understanding what may be going on. So I think that's really important, but absolutely it can be diagnosed after infancy, and often is. And, I sent out an article about misdiagnosis. I think it's very important that, we're talking about that and thinking about that, and not just in people who maybe have had their child removed, but, talking about it with all of our families, and really making sure that, this is a legal, not illegal substance. And, as we saw, many people don't know they're pregnant for the first 2 months. And so just talking about it, normalizing it, but also making sure we're not overlooking that as a possibility.
Just a couple more questions. If depression is experienced by the mother, does her affect create similar affect in the child?
So I think it could, think about the serve and return. Think about how great that dad was when the baby laughed, he laughed. He was mirroring for that child, what he was seeing. And babies do the same, they're looking at us to know how to respond. So absolutely, I think, when you have a parent who is experiencing depression, it's going to be very important, to look at the social emotional well-being of the child and to know that those impact each other.
Our next question, I think, will also be really interesting to you, Megan. Has data been gathered on the rate of need using the ACEs questionnaire?
Has data been gathered on the rate of, say that again?
So you showed us the rate of need for healthy steps, and this person is asking about rate of need with respect to how people respond on the ACEs questionnaire.
Yes, so has data been gathered? Yes. The answer is yes. I don't have some of the numbers off the top of my head. I would say ACEs Aware is a great website to look at. Our first Surgeon General of California, Nadine Burke-Harris, has instituted ACE surveys in pediatric offices and is paying people to administer this survey. So there's definitely more and more data. I know at our Kids Start program at Rady Children's, we have looked at our rate of ACEs. And Dana, make sure I'm understanding the question. The rate of data just in general, or like, are we looking at how significant they are, or what areas were most impacted, or?
I think the areas that are specifically impacted. You had showed us the slide that sort of showed what you're finding in terms of the people who are coming through healthy steps in terms of their children's rate of need for various concerns. And so I think this person is looking at how that might correlate with ACE scores or ACEs data.
How the rate of, I don't know the answer to the correlation there, but I think, and I'll make sure I understand the question, but I think it can be bidirectional, right? So, a developmental child with developmental issues may be at higher risk for abuse and neglect and things like that. And then vice versa, we can, kind of have a child who is neglected, who may look like and show concerns for autism on a survey tool, for example. I don't know if that answered that question or not. But I would say look at ACEs Aware. I'm sure that the state of California is doing a good job of gathering some data. I know within the clinics where we give the ACEs, we're looking at our own sort of outcomes there, but I don't have that data readily available.
Our final question for the day, since we have run over, we did commit earlier in the webinar to talking a little bit about referral. And I guess 3 parts to this, right? We want to talk about referral for early childhood. since this was sort of the substance of the training. But the person who raised the question raised it for kids who are older than early childhood, because there are some really logical pathways in California I think we could speak to for early childhood that are still really important to talk about here. But sort of talking about then where to refer older children. The person who asked the question is specifically asking about a family in Riverside County, but we know that this is a challenge for counties across the state for older kids. So talk a little bit about that.
Well, just yes, to validate, it is a big challenge, and there's not enough support out there in mental health for any age, and there's a huge need. I think, you know, in Riverside County in particular, we just, I know there's two people on this presentation who are a new mental health therapists for our younger kids. And I, in terms of, you know, paying attention to the needs of the family system, the siblings, the older siblings, teenagers, I think, you know, that is a huge, there's a void in our system in terms of availability. In terms of where to refer, gosh, I wish I had more places. You know, I think always going to the behavioral health side of your insurance is a good place to look. There's places like Smart Care and 211 that are good. You know, sometimes going to your medical home, to your pediatrician, because they are getting this a lot. It's often the place where families go. You know, here at Rady's, we certainly have a lot of great supports, particularly families with Medi-Cal, where there's that need for older children. But we have a lot of work to do in that area. I wish we could do better. I'm glad you're asking the question, though, about the older children when you're working with the younger one, too, because that relationship affects the other, you know, and so it's very important that we're thinking about the family system as a whole.
And for younger children, for folks who may or may not be as familiar on the webinar with sort of the referral pathways, what might you recommend? Knowing that a lot of people aren't necessarily working in a medical environment, a lot of folks are coming from, say, family resource centers or schools that are on the call.
Gotcha. I think depending on, you know, gosh, where to go? I mean, that's a pretty broad question. I think, you know, I think here at Rady's, we do a great job both in Riverside and San Diego County in terms of providing support for the younger ones. First 5 funded programs are a wonderful place to start for, you know, those concerns. And I think that's a good referral. HowKidsDevelop.com is a great resource in terms of what's available and different places where you can get some screening done to hopefully help then, you know, link you to further support, whether it's developmental or mental health.
Great. And then I just saw in the chat, we've added Help Me Grow Inland Empire is a good resource. And that is another good one since it goes up to age 8.
That is a really good one. Yes.
Well, we really appreciate your time, Megan, particularly staying after to answer questions and for all of the really great information and really sort of break down what are we talking about when we're talking about early childhood mental health. As a reminder, if you are still with us, we will send out another message in about 2 days. It'll go to your registration email. It'll have the recording. It will have all of the resources. And again, a link to the survey, which I am going to drop again. And absolutely, I'm seeing some comments about let's do more on this. You are going to see a couple of webinars coming up. Definitely do attend the protective factors webinars. They really do go in depth in each of those factors. We've got one coming up on perinatal mood and anxiety disorders, which really speaks to the mental health of the whole family. And we have another one actually in April coming up on helping parents with their own ACEs. And really looking at how that impacts treatment of their children. So this is going to be a big thing this spring. You're going to be seeing a lot more early childhood mental health coming your way. So again, Megan, we really thank you. I'm going to drop the link again for the survey. Do feel free, everyone, to stick around so that you can access that. And if you have any questions, feel free to let us know in the chat or to send us a quick message. And I will drop our email address in the chat as well. Thank you so much for joining us today, everyone.
Thanks, everyone. Dana, do you want me to stick around or do you want me to jump off?
You are welcome to jump off anytime. We really appreciate your time.
All right. Thank you for your support. Have a good rest of your day.
Bye, Megan.
Bye.
And everyone, I am going to drop this evaluation one more time.